This is Dr. Howard Strassler talking about posterior composites and understanding light curing for improved clinical success. When we talk about light curing, we're talking about light curing for all restorative materials that we're using, and the basic concepts and understandings really fit with all materials that we light cure. And think about what we're light curing today. We're light curing adhesives, restorative composites, sealants, ceramic veneers, ceramic inlays and onlays, fiber posts, base and liner materials. Prosthodontically, tray materials are light cured in the laboratory. Denture-based materials can be light cured. Our prosthodontic provisional materials, both in lab and in office, can be light cured or dual cured. Some of our desensitizing agents are light cured, and we're using lights to also activate bleaching agents. The majority of direct composite restorations that we place today are composite resins. In fact, of the over 130,000 general dentists in the U.S., if we take a look at how many direct restorations have been placed, it's over 122 million. From a 2005-2006 survey of dental services from the American Dental Association. Plus you can include veneers, plus you can include orthodontics, all used light curing of some sort and relied upon the same concepts of principles for light curing. The National Institute for Dental and Craniofacial Research in 2009, in their strategic plan, made a statement. Despite steady progress in learning how to better formulate and cure hardened dental composites, studies have shown that dental resins last an average of only 5.7 years due to secondary decay or fracture of the restoration. And so what we're going to do in this e-lecture, e-presentation, is really get a better understanding of light curing based upon the physics of light curing and the physical properties of the materials that we use when we're restoring teeth. There's a lot of research that supports light curing and understanding the science of light curing. This research includes our clinical testing and our clinical techniques. It includes an evaluation of the physical properties of our materials with adequate and inadequate light curing. And so, as we said, in 2005-2006, over 122 million direct resin restorations were placed. In January 2011, Gordon Christensen in Dental Economics wrote about the fact that 1/3 of the dentists in the United States who were general dentists have eliminated amalgam from their practice, making direct composites our primary restorative material. In fact, in the last 12 months, in the U.S., the ratio of composites placed compared to amalgam, for every 2 Class II composites, there was only 1 Class II amalgam. These are significant things that have a direct impact upon can we get the clinical success of these restorations comparable to what we've seen in clinical trials with amalgam. The problem is, when we look at light curing, we take it for granted, we become complacent. I think of the Geico commercial, light curing, so easy a caveman can do it. And in fact, light curing does require an understanding and techniques to assure longevity of the restorations we place. In fact, that's the problem. The process of light curing is treated with very little regard to the type of science, the exacting science it is. We look at it as too easy. And even when we do very minimal attempts, poor light curing techniques, the top of the restoration, the surface, appears to be acceptably hard, when in fact, deeper in the preparation, at the cavo-surface margins that may be cervical to the occlusal surface, we're not getting adequate hardening, adequate light curing of the restorative material. So let's understand the challenge. We need to teach our students, our clinicians, how to use their light properly and what affects the extent of the cure of the restorations we place. We need to understand what spectral output of the light means. We need to understand what the spectral needs of the composite are. We need to understand what the difference is between the concept of irradiance and energy density. And we need to understand how the duration of exposure and spectral delivery affect the final cure of the restoration, with understanding what those needs of the composite are. All composites need different amounts of energy in order to light cure. In fact, one of the problems that we have with not curing composite completely is the fact that we're not getting adhesion. We're getting lower bond strengths, we're getting increased microleakage, and at the cavo surface margin, we're getting increased recurrent caries. And in the image on the right-hand side, you can see in the corner of a proximal box of a composite restoration that the uncured resin at the tooth interface in a high-risk area will get recurrent decay. The other problem with inadequate light curing is that we'll see color changes of composite. In fact, we'll also see increased wear of the restorative material. We'll see premature restoration failure. And not all light curing lights are the same. In fact, even though they appear to be the same, that they're high intense blue wavelengths, there are differences from light to light, system to system, based upon the tip, based upon the light emitter, the LED, based upon the wavelength of the LED or LEDs, their placement, the number of chipsets that are in the LED, the batteries that are used, or is it running off a power cord. Lots of differences. So let's take a look at the words and the concepts. When we say power, we refer to it as milliwatts. You know light bulbs as being 90 watts, 60 watts, 100 watts. This is the power of the bulb, its brightness of the bulb. Brightness does not speak to the wavelength, which is critical to the chemistry that we use with our composite. Our composites have photoinitiators that are sensitive to very narrow bands of wavelengths of light in order to light cure. So when we look at irradiance refers to the milliwatts, the power of the light, over a certain surface area. In fact, on this graph, you're looking at a number of different light sources that have different power curves over different timed areas. In fact, all the surface areas that you're looking at are equivalent for all of the lights that we're looking at. What differentiates them is the duration that the light was on, and the lower curve, the purple, that it took 20 seconds to reach what was necessary with the light that is measured with the blue curve at 5 seconds. So that power per unit area is very critical in telling us the amount of joules per centimeter squared that we need, the energy required to cure a composite. We need to understand the spectral radiant power in milliwatts per nanometer, nanometer referring to the wavelength, that depending upon the photoinitiator, the composite needs a very narrow wavelength of light in order to fully polymerize. And here we're looking at what's referred to as a polyphase light that has one wavelength in the violet range at around 390 to 410 nanometers versus a blue chipset of LEDs that are in around the 450 to 460 nanometer range. The total irradiance of this light is 1735 milliwatts per centimeter squared. The problem is that a portion of this spectral radiant energy is in the blue and another portion's in the violet. If your photoinitiator is only in the violet range, then you're not having enough energy to cure. If your photoinitiator is in the blue range, this 450 to 470 nanometers, then we're going to need an increased time because the total spectral radiant power really is referring to a combination of violet and blue. And so through this understanding the power, the irradiance, the spectral radiance power based upon the nanometers, the wavelength of the light, that we're going to come up with an energy density. An energy density is irradiance over time, the duration of light curing. And it's been said that composites need a minimum of 8 to 16 joules per centimeter squared. And for this composite, 3MSP Filtex Supreme Ultra, they tell you need a minimum of intensity of 400 milliwatts per centimeter squared in the 400 to 500 nanometer range. Well, that means violet to blue. How much blue do we need? How much violet do we need? In fact, you'll see on the bottom, under shades, that a translucent composite at a 2 millimeter increment needs a 20-second curing time at 400 milliwatts per centimeter squared, but the darker, more opaque shades need twice the amount of curing time with this minimum intensity light. In fact, we don't have enough information about the composite. What is the range of the photoinitiator that is sensitive to the light source? In fact, it caused the fact that Dr. Richard Price came up with and invented a device called MARC, stands for Managing Accurate Resin Curing, to scientifically measure and look at the accuracy of these lights in light curing. And at University of Maryland, we happen to have one of these devices, and you'll have the opportunity, if you'd like, to use this device to look at the lights that we use in the clinic. Also learn the principles of light curing through a feedback and training using this MARC unit. So MARC is a scientifically accurate and relevant, easy-to-use device where the spectrophotometers are actually embedded in teeth in a typodont in a mannequin head. They're calibrated so that I can look at the MARC and actually measure what's going on and see how well you're light curing. We can look at the light spectrum on this curve, and this is from the MARC software. We can see that energy in the 420 to 540 range is giving us 12 joules per centimeter squared with this blue LED chipset in a curing light, and this happens to be an Ivoclar Blue Phase 16i. Now I take another light set, a Blue Phase G2, which has a violet range and a blue range, and the total irradiance is 1200 milliwatts per centimeter squared, but some of that energy is in the violet range, as you can see by the energy that's circled on the left-hand side, and some of it's in the blue range. And so if we have a composite that has camphorquinone, CQ, that we only can use the blue wavelength light, having the violet doesn't do anything to help us for our adhesive, for our composite light curing. What's also scary is that the chipsets itself don't give us a uniform beam profile, and the beam profile refers to that across the light, and when we look at it with our eyes, it appears as if the light is uniform, when in fact when we take a MARC unit, we can measure the beam profile, and here we're looking at this light that we're evaluating has 3 chipsets, LED chipsets, and across the tip of the light we're getting ranges of irradiance that are 388 milliwatts per centimeter squared at the lower end of some of this tip to as high as 5800 milliwatts per centimeter squared. And so our irradiance has a significant difference. We can't assume that just because the light's turned on, it's uniformly curing the composite. In fact, it isn't uniformly curing the composite. In fact, we have an uneven beam distribution, and on the right-hand side you can see from this this photograph, we can actually evaluate and see hot spots and cold spots in the curing light, which means that if you look at the middle image, if this were a premolar with a class 1 cavity preparation and we're light curing it, the middle area is light curing pretty well, but in the edges we're not getting the adequate light curing at those cavo surface margins. This evaluation in the science of light curing is very critical in terms of what it means to success. Also, we as operators, if we put our light tip, as we can see in the upper left-hand corner, on the occlusal surface of the maxillary first molar, and we measure the light, and then we were to take this tip and we were to rock it a little bit or move it a little bit. If you look on the lower right-hand side using the MARC software, we can see that as just a little bit of movement of the light changes the profile of how much light energy we're giving to a composite that might be in that tooth. A little bit of movement really makes it more difficult. In fact, how do we make this science relevant and create value to your education, to our faculty members' education when you're in private practice? And really, for a clinical procedure, we're using a curing light between 15 and 60 seconds to cure a restoration. Here we see a premolar that has a matrix band on, and the light's been turned on. We've now got a photo of light curing the occlusal surface of a class 2 composite restoration in a mandibular premolar. And so understanding these concepts of light curing are going to give us improved clinical success because light energy matters. Now, what's interesting is when we take a look at posterior composites, composites that we're using, that the safety of composites has been very much open to debate. The science does not demonstrate that amalgam has risks involved with them in terms of what testing's been done. From 2 studies that were published in the Journal of the American Medical Association looking at neurobehavioral effects and neurophysiologies that could be measured for children comparing dental amalgam to composite, that these 2 studies in JAMA were really very interesting because they were addressing the concern that the mercury vapor released by amalgam, do they cause adverse health effects with children? In fact, these studies were so important that they made the front page of the major newspapers in 2006. And you can see in the Baltimore Sun, silver fillings found kids safe. Traditional tooth care contains mercury, but doesn't harm children, major studies indicate. And what was interesting from these studies to me was not that you should start doing amalgam again if you have switched to composite, but rather are there interesting things in these studies that relate to how these restorations serve the teeth, how they serve the patient. And what was interesting is that there was no difference in the nerve velocity and conduction and the neurobehavioral assessments with children who had composite or had amalgam. But there was a trend for higher treatment need later among those receiving the composites. That suggests that amalgam should remain a viable option to restore children's teeth. So the composites didn't last as long, and this was a 5-year study. In the 7-year study, the last one was 7 years, this is the 5-year study, that there were no adverse neuropsychological effects observed. But in fact, the amalgam restorations lasted longer than the composite. And so the effects of amalgam shouldn't be our basis. And in this study in Journal of American Dental Association 2007, Survival and Reasons for Failure of Amalgam versus Composite Posterior Restoration, that what this study showed, and we'll look at what it looks at, Secondary caries was the main reason for failure of both materials. The risk of secondary caries was 3.5 times greater for the composite groups. In fact, the amalgam restorations performed better than the composites. The difference in performance was accentuated in large restoration in those with more than 3 surfaces involved. And the implication was the use of amalgam appears to be preferable to use of composites in large multi-surface restorations in posterior teeth. But that ship has sailed. We're going to be moving towards composite. We're going to be doing more composite restorations. Many of you may not do amalgam in practice. But why are we seeing these failure rates? And when we look at the data very closely, we'll notice that we're seeing recurrent caries at gingival margins of class 2s. Teeth restorations that are more difficult to light cure, to get full polymerization, full adhesion in a high-risk area, which is that gingival margin of class 2s. In fact, from this study that was published in the Journal of Dental Research, that when we looked at the further away we are from the light source, from the tip of the light, the less irradiance that we're seeing. And you can see that at the light tip, for depending upon whether it's a plasma arc lamp light, curing light, whether it's an LED or whether it's a quartz halogen, that for all the light sources, whether they're a high energy light or a lower energy light, that as we move further away, 5 to 6 millimeters away, we get drop-offs of 20 to 50, 60% of the energy we're delivering. In fact, when we're curing adhesives in deep proximal boxes, the recommendation's been made for a curing light that has at least 600 milliwatts per centimeter squared, and that's measuring it right at the tip, right at the orifice, that we should increase our curing time in deep proximal boxes to 40 or 60 seconds. In fact, to maximize the energy that we're delivering, the operator should wear eye protection, blue blockers, orange glasses, or use orange shields. They should watch what they're doing and should hold the light both close to and perpendicular to the restoration. We'll talk about rules for light curing that we can follow. So think about it. Where is the light relative to what we're curing? And on the left-hand side, we can see a curing light touching the cusp tips of a mandibular molar. That the light is already about 1 millimeter away from the cavo-surface margin. In fact, if we look on the right-hand side, the light is 5 millimeters away from the proximal box in this very routine class 2, but really this is a lie. We're not touching the tooth when we're light curing a class 2. We're actually hindered by the fact that the matrix band extends a little bit higher than the tooth itself, and so we may be upwards of 6 millimeters away. How does that translate to the energy that we're delivering? Well, let's take a look. A good curing light. A curing light we have in the clinic, we've measured it between 1200 and 1000 milliwatts per centimeter squared. For this light, which measured at 1400, and then measuring the distance away, as we were going into a proximal box 5 millimeters long, that we had an energy drop-off of greater than 50%. We started at 1400 milliwatts per centimeter squared. We've dropped to 600 milliwatts per centimeter squared, which means we need to increase the duration of light curing. For the lights we have in clinic, which are measured at around 1000 milliwatts per centimeter squared, we even lose more energy as we get to the proximal box, where we drop down to 370 milliwatts per centimeter squared. That means we're delivering less energy in a given time period at the gingival box than we are at the cavo-surface margin. And you can see that there's a drop-off at the cavo-surface margin of over 10% of that difference. So what are we going to do to optimize our light curing? If we look to the left-hand side, there's the light on a premolar, light curing and distal occlusal restoration, with the light as close as possible being held up by the matrix band. We're at right angles to the tooth, as close to the tooth as possible. Because keep in mind, in many cases, the matrix band moves the light further away. So we're at right angles as close as possible, and we're directly over the area that we're light curing because there's a given diameter of that curing light. In this case, the light's being misoriented. Note the height of the matrix for this premolar. And this is what I saw one of the students doing. This is a picture of how they were light curing. They turned on the light and they looked away. They weren't using an orange shield. They weren't using blue blockers to block out the blue wavelength of light. And they weren't adequately curing this composite. We had them go back and reorient the light to be at right angles and as close to the tooth and directly over the tooth preparation that was being restored. The light may not be working properly, and these are curing lights that were in our clinics that were handed out and the students were going to use them. You can see the tips are broken or have materials cured on them, and we're not getting these lights to work optimally. You need to inspect the tip, you need to inspect the rod, the probe, the fiber optic bundle of the curing light. And so MARC gives us the ability to measure these things. It has both an anterior sensor and a posterior sensor. We can use it for training, and we can use it for evaluation of the curing lights that we're using. Operator technique comes into play. Stabilization of the light. In this lower right-hand corner, the light's being placed on the occlusal surface, but it's being held in space. It's not stabilized with a finger rest, and so the light is moving. A little bit of shifting has a major impact upon the amount of energy we're delivering. And so good curing habits really rely upon core values. Core for curing light, the light we select, operator technique, the restoration, location, depth, size, patient's opening, and the energy requirement of the composite we have. Darker shades need more energy than lighter shades. Different composites are more opaque and need more energy for light curing. And so we need to know our curing light. And here we're looking at a variety of lights. In the upper right-hand corner, we're looking at a quartz halogen light. In the middle, the light looks like a gun with a cord attached to it. That's a plasma arc light. And all the other lights that we see are light-emitting diode chipset lights. Some of them polyphase with both violet and blue wavelength irradiance, and some of them just blue in terms of the chipsets of the LEDs that are in them. And here, we give the curing light, same tooth, same length of time. And we give these 37 operators and we say, we like you to use the curing light. We don't train them, we don't teach them, we don't tell them anything. We just tell them to cure as if there were a restoration on the occlusal of tooth number 14. You can see that the variation in the amount of energy these operators are delivering is significant. I mean, one operator was outstanding, the upper red, but then there were some where there were significant drop-offs of power. And keep in mind, they know they were being measured, so if anything, they were competitive to do their best. The optimal for this test would have been 8.0 joules per centimeter squared based upon the irradiance and spectrum, all the data for this light. But the range for the operators was between 0.9 and 7.2, where the average was 4.1 joules per centimeter squared, extremely inadequate for curing a composite resin on a posterior tooth or an anterior tooth. And so you don't want to be distracted. You want to focus in on what you're doing. You've got to be able to see the tooth that you're curing. In fact, in the right-hand side, You notice the operators wearing blue blocking glasses, orange glasses. They are stabilizing the light with their finger on the light tip. They're looking where they're placing it, and they are using the light correctly, where they're as close to the tooth as possible at right angles, running for the full duration of the curing light. And so after we instructed same light, these operators, they did much better. In fact, the range went from 5.8 to 7.6 with an increase of 50% over what they had originally. Remember, the original average was 4.1. Now we're seeing 6.7 joules per centimeter squared, where the absolute optimal that anyone could get would be 8.10 joules per centimeter squared. You need to know the light tip diameter, and in our clinics with our satellite lights, the diameter is 7.5 millimeters. So if we were doing a sealant on a molar, we'd need to cure for 2 cycles to cover the entire occlusal. If we were doing a class 1 occlusal composite, we'd have to do the same thing with overlap through our curing both mesial and distal, running it at, if the preparation has a depth of 2 millimeters, running it for 10 seconds for each cycle. Darker shades, 20 seconds for each cycle. On a premolar, there would be no need for overlap, but with a matrix band in place, we're going to be further away, so we're going to increase our light curing for a class 2 in the proximal box to do at least 30 seconds for the adhesive and the first increment of composite. The class 2 on a mandibular or maxillary molar, once again, we're overlapping, and because of the proximal box, and in the lower right hand side, if you look at the proximal box, it's completely covered by the diameter of the light that we're using. If we're doing class 4s or facial veneers with composite or porcelain veneers, once again we may need to do overlapping depending upon the diameter of the light, besides being at right angles and as close to the tooth surface as possible, running the duration a minimum of 10 to 20 seconds. In some cases, darker shades, we may need to do 30 seconds of light curing. The light has to be able to get to posterior teeth. In this case, we're looking at do we have access to the maxillary second molar. A 30 degree angle of our curing light to a restoration surface can reduce the surface energy we're delivering by 26%. So these are negative effects of light angulation, light movement, to the type of clinical success we'd like from our adhesive restorations. So let's change the angulation. What we're looking at on the left-hand side is a composite resin that was placed in a straw with a thickness of 4 millimeters. We then took a light with a mylar strip and placed it directly on top of the straw and turned on the light for 10 seconds. It was an A2 shade composite. I then took the composite out of the straw with a scalpel, scraped it, and I can say I could pretty much get that 4 millimeters of light curing top to bottom. But now I take that same light and I angle it at 45 degrees to the surface. There's the mylar strip. When I look at the illumination of the composite, it looks exactly the same. After running it for 10 seconds, I then scrape off the soft stuff, and what do you notice? That the curing really is occurring based upon the angulation of the light, even though to my eye it appeared as if the entire cylinder of the straw was being illuminated. Not enough energy was being delivered to polymerize the composite, to harden the composite. The top surface was adequate, the interior surface of the composite were not. And so we need to understand the energy requirement of the composite. The power of the light, the irradiance over the surface area, and then the spectral energy based upon the wavelength of the light that we're delivering. Then you include the time that we're light curing, and we'll come up with the energy density that we're delivering. And that we need a minimum of 8 to 16 joules per centimeter squared, depending upon the composite that's there. Not all lights are the same. Not all lights have the same beam profile of how the light's being delivered. There are a lot of factors that come into play. So how do we ensure better light curing? Well, number one, we're going to wear orange glasses for blue light blocking. So safely you can watch what you're doing and know where you are. You can have the orange shield between your eyes and the light curing light. We can move the patient into a position so we can see the restoration where light curing it and access it with the curing light so we're at right angles and directly over the preparation. We want to position ourselves comfortably so we can stabilize the curing light exactly over the preparation. We're going to adjust the light guide so you can operate it comfortably, and you make sure that the tip is clean and the light is working optimally. We want to stabilize the curing light so it's perpendicular to the surface of the resin. And what I like to do is I begin curing 1 millimeter away from the resin, I move it closer. And the reason I do that in that first second is that if you just position it in space and you don't concentrate on where you're positioning it, it's going to move. You won't have the stability. And then for larger restorations and multiple curing cycles, you'll either wait between each curing cycle or you'll have your assistant air cool the tooth to limit the temperature rise due to the curing light itself generating heat and the heat of polymerization of the composite. Well, what it really comes down to is when you understand light curing, you're going to get improved clinical success because light energy matters. And hopefully I've given you a little bit of luminescence today about light curing and how it impacts upon the restorations that we're placing. You've just viewed and listened to the e-presentation, e-lecture on posterior composites, Understanding Light Curing for Improved Clinical Success.